at least here at UCLA, we are very limited by the patient's funding resources. They have different types of health insurance, they have different things that are covered. So we have to design a program that, will fit with what their healthcare funding is. My center used to be a multidisciplinary post-polio center. Changes in funding, resulted in us becoming a center without walls. So we do a lot of networking within UCLA and in the community to find resources that we can rely on. So, we have a long list of pools that could be used by people with handicaps and what their temperatures are and how accessible they are. We have a list of community orthotists and community occupational therapists and physical therapists so that, we can respect, the problems with travel and transportation in general, and also the problems with funding.
Kind of an important thing that I find is that not all post-polio clinics are the same. It really depends, I think, on the leadership of that clinic, what how the patients are evaluated. Now, Rancho, because of Dr. Perry's orthopedic background, it's very much orthopedically, mechanically, that's where our strength is. Now, other centers probably do some bracing as well and so forth, but in terms of having these kind of orthopedic types of perspective on polio, I think this is probably one of the very unique centers that they have. I think what I kind of add to it a little bit is because of my rehab and internal medicine background. That adds a little different flavor to it as well, where we talk about pulmonary issues and things like that. We're able to offer that. And again, it's a little different than probably a polio center run by a neurologist, because they also come from a different perspective.
Yes, we were at UCLA yesterday meeting
Right.
Dr. Perlman. Yeah.
Right. So, yeah, I think so. I guess my point is that polio clinics are not the same. It really depends on who is sort of the philosophy behind how they treat polio, and I think each center has sort of their unique strength. And I think our strength is really in terms of maintaining and improving function, and just an orthopedic perspective of looking at gait, normalizing gait as much as we can. Our clinic is extremely strong, and I think we provide the best care in terms of analyzing their gait, normalizing it, understanding the reasoning behind why they walk the way they do, and that's very important, because if you walk kind of funny, you compensate by using back muscles, and then you use shoulder muscles, and then everything kind of, falls apart from there. So we really get to the root of the problem and correct the issues that actually will help multiple of other issues. So somebody comes in and says, I have back pain, and we give them a brace. It's like, okay, how is that related? But, when they come back, voila, their back pain is better, because we corrected how they walked. So the resident and the physical therapist, they both go in. That probably takes, I would say, anywhere from 30 to 40 minutes, and then we all discuss together as a team.
Including the polio patient?
Yes, well, we first have a pre-discussion. You'll be able to see that, and then we actually go all together as a team, include the patient in the discussion. We do the observational gait analysis together, then we make our recommendations, and then an occupational therapist goes in and she does the counseling on lifestyle modification, and so the whole process, I would say, probably takes at least a couple hours, but there's kind of breaks in between, because we're seeing other patients as well, but I think if you put it all together, probably a couple hours. I think the unique aspect is that not too many polio clinics have access to the orthopedic surgeons at their fingertips. So here, basically, if we say, a brace is needed for this patient to improve function, but the person has some sort of a deformity of the foot or the leg or something that cannot tolerate the brace, and then we have the orthopedic surgeon who basically says, we can do this, we can correct this, and then we could then, put the brace on, and then, and so we have this whole picture, whereas probably in other areas where they don't have an orthopedic surgeon who's actually running the clinic would have to then refer somebody to an orthopedic surgeon who might not have a full idea as to, okay, why are they doing that, and it's not really part of the team, so I think those are kind of the features.
We talked about muscle testing. Muscle testing is very important in this institution. we work very hard to get accurate. Because muscle testing is hard work. If you just do this, that's not fair plus. That's
Yes,
and
yeah.
so we use that our muscle test as a guideline.
And EMG?
No, I use EMG if we have a question I can't answer clinically. You don't use it very often. It's a gate usually or upper extremity.
Yeah, one of the things that we educate our residents about doing muscle testing and so forth is that we really emphasize the muscle testing as not only to see if there's a connection between the nerve and the muscle, but we're wanting to see, does this person have enough strength and capacity to perform function? And it's a totally different perspective of looking at muscle testing. So and a lot of times, because muscle testing actually takes a lot of time, it takes patients, they have to undress, get on the table and so forth, and then in the era of this HMO where you have to see patients every 15 minutes, 10 minutes and so forth, if it's done very minimally.
Rudimentary, yeah.
Right, it's kind of like, okay, can you lift your hands up, and okay, can you do this? But, that's about how it goes, but you'll be able to see that we test each muscle with the understanding that we need to know what that muscle can do. So we could recommend, for example, how much exercise you can or cannot do. Whether you need braces or not, and we're answering these very fundamental functional questions based on this muscle testing. So that's one thing that we get, and it's always double checked by Dr. Perry, because the therapist, might put a bunch of numbers on there. We watch him walk, and Dr. Perry would often say, "I don't think that quad is a 2," And sure enough, we have him go check it again, and it's not, So it's a really quality controlled muscle testing, not just, anybody doing it. And
Dr. Perry, you have to live forever. You know that, don't you?
I think so.
and some of the residents and stuff, or they sometimes do their own muscle testing, and we tell them, no, that's that can't possibly be right, because this is what we see, and they're kind of amazed at how Dr. Perry would know that, and she has not even seen the patient yet, So
after X amount of years, I suppose you just know.
Well, that's right. Function has certain minimum requirements on strength.
Right. So the muscle testing is one of the fundamental basis of our evaluation. And the thing is, it's and as you know, one of the hallmark of polio is that you have the range of disability in polio is from 0 to 100%. So, and anywhere in between, it could be, 55.7% disability, and the next person is 55.2. I mean, and it's very distinctly different. It's very difficult to group them together. And the only thing that for us that we could use to quantify, okay, what does this person can do that this person shouldn't do? In some cases, we tell our patients, yeah, you need to exercise more because you got weak because you're deconditioned. And in this person, you got weak because you're working too much. You're going over capacity. But you can only give these individualized recommendations based on these individual muscle testing. There's actually just no way around it. I can't look at you and say, I think you need to not exercise, or I think you need to exercise. I mean, it's even to the specific as to, you could exercise this left leg, but not the right one, or, And that only can come from an accurate muscle testing of the entire extremity. So you really can't make a blanket post-polio syndrome recommendations that will fit all people. You really need to have it individualized, and so that evaluation and a thorough evaluation that incorporates muscle testing is probably one of the most important things you can do.
So perhaps you could just tell us a little bit about how your clinic works here.
Well, it's a multidisciplinary, or the better term is interdisciplinary, which suggests that people work together. It's interdisciplinary, one-stop shop. It extends over a day and a half. And the clinic process, the clinic schedule has evolved. So, I mean, the reason that it's set up this way is as a result of a lot of experience. and a lot of thought and planning. I ran a clinic in Houston starting back in 1984, which was probably one of the first clinics in this country. But we really didn't know what we were getting into, and we had an enormous number of people who came, and it was quite fragmented and helter-skelter, and there wasn't any kind of coherent presentation. So when I came here, I requested from the administration that we set up a planning group, and we actually spent 6 months meeting weekly to think through how we wanted to do this, what areas we wanted to cover, what disciplines should be involved. The hospital was a bit different then, so we had access to more resources than we have now. We had a very active respiratory lab, so we could get pulmonary function tests, arterial blood gases.
No more?
No more, it's all across the street. It's close, but it's not in the same building. And we had speech pathologists heavily involved because we were doing a lot of work on swallowing problems. So in any event, it's evolved over the years, but the basic features have been always the same. A clinic, because of the complexity of the average patient who presents to the clinic, it just didn't make sense to try to do it all in 1 hour or 2 hours. I mean, that was just, it's not practical. And you can't do a thorough job, and you leave the patient, I think, without a full explanation of their symptoms and a coherent plan of how to deal with their problems. So that's been sort of our objective. So they come in the first day and they see the physical therapist for roughly an hour, then they see the occupational therapist for roughly an hour, and then they see myself. Or when I've had another physician, they would see that physician. And each of us had a team that we worked with. A physician who was here for a number of years, who was an excellent colleague, that just recently left. So it's just myself at the present time. In any event, when I see the patient, the focus is on their polio history, their general medical history, other medical issues, problems, and then with a really very incisive look at their neurologic picture. So not only neurologic history, but a very comprehensive neurologic exam, because I want to make sure that there isn't some other neurologic explanation for new weakness, fatigue, etc. And as we mentioned earlier, I mean, post-polio syndrome is a diagnosis by exclusion, and I take that very seriously, so that I really tried to look at all the other kind of obvious possible neurological and medical diseases that could be causing the symptoms. So that's sort of my task. And then the PT and OT have each of their own separate areas. And the nice thing is then I don't have to do, sort of a shoddy, half of a baked physical therapy workup. I mean, that's done by an experienced therapist. And the same is true for the OT and then the social worker. So anyway, the second part of the first day, after lunch, let's say, if there's any lab tests, x-rays, or electrodiagnostic testing, that's done in the afternoon. And then the second day, they actually see the social worker, and they see the physical therapist, occupational therapist for kind of
An update.
a chance to sort of ask additional questions. I've now talked to the two therapists about the results from lab testing, EMG. So if it looks like, let's say, their arms are polio-free, they can show them some of the equipment that's available for upper extremity exercise. It's also a chance to talk about wheel mobility, if that's an issue, or maybe using a cane or forearm crutch or whatever it might be. Because we find frequently on the first day, folks are a little bit reluctant to make a change. I mean, sometimes very reluctant. I mean, they're in denial. They don't, they don't want to look disabled. They don't want to use that cane. They don't want to, But often by the second day, they've had a chance to sort of sleep on it. We encourage people to bring their spouse or significant other, someone they can talk to. So the evening is an important time for things to sort of percolate, for people to digest what they've heard, integrate it. And so they come back the second day, and they'll often have, a little different perspective and be more willing to hear different things and maybe even try different things. So that's why the second day is really critical, because we can already take that first step to doing some very specific management things. So it's not just all talk. And that's a really key part of the program, that we go from, evaluation to sort of plotting out a course of intervention, give the patient the time to digest it and be perhaps more ready to accept it, and then give them some very specific, concrete things to do, to try out, right while the therapist is there. So it's not theoretical. And then, at the very end of the morning of the second day, we have a sit-down conference for half an hour with everybody who has seen the patient. So the therapist, the social worker, myself, patient, their significant other, and it's a time to just pull everything together.
Is the orthotist brought in at that point?
No, I'm sorry. That's a good point. The orthotist usually sees the patient on the first day. And because their contact, they don't tend to spend a lot of time taking a history, and usually the brace can't be manufactured, overnight. So mostly it's an evaluation and a recommendation, and then they might come back later to get a brace, fitted. But anyway, the closeout conference is really key because it sort of pulls everything together. And we review our findings, we review our diagnoses and our recommendations. And it's a chance for the patient and, say, their spouse to ask questions. And the reason I like to have everybody around the table is so that we're all sort of, reinforcing each other. And if the PT says something that, I don't quite agree with, we try to thrash it out right there, so the patient doesn't leave with mixed messages. And then, as we've talked about, there's a little sheet in which each of us lists our 2 or 3 key diagnoses and 3 or 4 of the key interventions. So the patient has something very concrete to take home with them. And then I dictate a report. I would dictate a report from the first day of my evaluation. And then the second day I do a dictation that summarizes the conference. So that gets sent to them in the mail a few days later. Again, so they have documentation, so they can read it, they can take it to other health professionals. So the whole idea is, really a strong emphasis on education. I didn't mention when the patient arrives, the nurse does a nursing assessment, and they present the patient with a packet of articles and information about the local support group, blah, blah, blah. So, the whole thing is to try to give the patient as much information as we can, hopefully not overload them, but do as thorough an assessment as we can given the time available, and then trying to integrate and make it all kind of come together. And I have to tell you that when people finish that conference, they inevitably say, "This has been absolutely extraordinary. This has been the best healthcare experience of my life."
One thing that I do need to know though is the day and a half clinic that you conduct here. If a person were to pay for that themselves, if they had no insurance as an example, what sort of cost would they be looking at?
The EMG tends to be expensive if that's part of a package. So it might be $2,000, $2,500.
Okay, so 2,500 for a 1.5 day session. But in this situation, virtually everybody is able to claim that on their health insurance. 100%?
Just about. Medicare pays for it. I mean, one of the things that we've done is tried to make sure that the services we get are, kind of standard, like the physical therapy. I mean, the physical therapist charges for the time she spends with the patient. So there's nothing special about the polio patients in that sense. And my charge is the same as it would be for spending an equivalent amount of time with, say, a patient with spinal cord injury.
Mm.
So it's sort of dependent on the time and the complexity of the way it works out.
The next time, if they came back in, say, 3 or 6 months' time,
Mhm.
just for a follow-up, what would be the time spent with them on that occasion?
Well, usually the follow-up, they see me. I
Mm.
mean, they may have been in the interval seeing a physical therapist for whatever, or an OT. They may have been going to the wheelchair seating clinic. They may have been getting a brace. So they've seen other folks. But then my role is to sort of try to pull it all together.
Mm.
And then I might see them for 30 to